On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Thank you very much, Roxana. Good morning, all. I would like to say that my partner, Dr. Samir Kapadia, led this project and prepared the presentation, but because of a family emergency, he had to leave, so I'm presenting on his behalf. 3-year outcomes of transcatheter aortic valve replacement is, of course, somewhat of a follow-up of the Partner B trial, which primary results were presented and published, as well as the 2-year follow-up. The objectives of our study was to evaluate the clinical outcomes of transcatheter aortic valve replacement compared to standard therapy at 3 years in inoperable aortic stenosis patients. Also to assess valve hemodynamics and durability using echocardiography as time is marching to 3 years and more so, and to perform subgroup analysis to better define the impact of comorbidities on outcomes. All-cause mortality clearly continued to show success, and the curves continued to diverge. At 3 years, only 19% of the standard treatment group patients was alive. So 80.9% 3-year mortality. This was reduced to 54% in the TAVR arm at 3 years. And this is a 27% absolute risk reduction in mortality at 3 years in this very malignant disease. Number needed to treat to save one life is 3.7. We also look carefully not only to the survival, but we also looked at the quality of life, and many measures were used, but one of the measures, I think, is the rehospitalization. So when we look at the rehospitalization, it was 75% in the standard treatment group compared to 42% in the TAVR group at 33% absolute risk reduction. When we combine the mortality and rehospitalization, it appears that only 7% of the standard treatment group patients were either alive and free of hospitalization compared to 66%. And we also looked at an interesting metric, that's days alive out of hospital. The median was 944 days for TAVR group. This is about 3 times, almost 3 times, the median 368 days in the standard treatment group. So this, and as you see, the curves continue to diverge as time goes on. There were 2 strokes between year 2 and 3. Neither of them were due to the device or the procedure. One stroke was in a 97-year-old man in the setting of severe cerebrovascular and extracranial vessel disease, as well as sepsis. And the second was in an 87-year-old man who is in chronic atrial fibrillation, but was not on warfarin anticoagulation. Well, we always look at the mortality or stroke as a primary endpoint. And as you see here, in this case too, the curves are wide apart. And there is the difference is 23% that reduced the death or stroke from 81% to 58%. One of the very rewarding findings that we had at the end of 3 years, when we look at the core laboratory, independent core laboratory analysis, is the fact that the improvement in mitral valve area from 0.6 to 1.5 at 30 days was maintained at 3 years, being 1.5. And the 3-year gradient of 11 millimeters mercury is almost identical to the 10 millimeters gradient at 30 days. With these findings, I think that we can drive these clinical implications. 3-year data continue to support the role of TAVR as the standard of care for symptomatic patients with aortic stenosis who are not surgical candidates. These data underscore the importance of patient selection before TAVR and need for aggressive management of illnesses after TAVR. Because when we looked at the stratified the mortality according to STS score, we were quite surprised that the high STS score in the standard treatment group was a very STS score in the standard treatment group really was somewhat irrelevant, because it's 78%, 80%, 100% mortality. It doesn't matter what your STS score is if you are not treated by TAVR. But if you are treated by TAVR, it makes an impact. I mean, you still have that gradations of increased mortality parallel to the SDS score, but you clearly see the benefit. Particularly in 2 to 3 years, you see the benefit at the very high SDS score level. So I'm happy to answer any questions.
Thank you very much. So the partner B, cohort B, is open for questions from the press, the panel.
Sure.
Dr. Gersh?
Oh, yeah, these are very impressive results. They really are. And I think no one questions the efficacy of the technique. Would you just comment on how this should be rolled out into the community at large in the United States? I know the College of Cardiology, Society of Thoracic Surgeons have come out with a white paper, and maybe this would be of interest to the press.
Yes. I think I would like to point out two critical elements in this effort. One is the concept of the heart team, that we have to maintain what is really a wonderful collaboration between multidisciplinary team members, the core being interventional cardiologists and the cardiac surgeon, but certainly with the imaging cardiologists, clinical cardiologists, cardiac anesthesiologists, critical care specialists, and if needed, geriatrician and neurologist and so forth. So I think that this team concept, not only in decision making, but carrying out this whole program. I think with this team concept also comes the fact that we should not promote a procedure. We should promote a program of taking care of high-risk valvular heart disease patients. This may be a surgical treatment. This may be a percutaneous treatment. This may be optimization of the patient's clinical status in the critical care unit. It may be balloon valvuloplasty. It may be a wise solution to patients' concomitant problems, be it cardiac, like severe coronary disease, or mitral regurgitation, or pulmonary hypertension, or non-cardiac illnesses. So I think it is critically important that we should not perceive what is accomplished with the partner program as only a success of a procedure, but rather how a program can be established with a multidisciplinary approach. That's number one. Number two, there is an unprecedented thing going on in the United States now. Now the premier Society of Cardiologists, ACC, together with the premier Surgical Society, SDS, got together with the government agencies of FDA and CMS, with the contribution of NHLBI and the Duke Research Institute, and we formed this core that runs the registry, a national registry that everybody in the United States, every single center that perform TAVR will put their devices in, will put their data in there, so that this will be a tremendous tool for us to be able to give feedback for quality improvement, to be able to monitor if we are really seeing indication creep, so to call, that we're performing these procedures in patients that really don't require to have these performed. So I think these methodological fundamental changes will help us to have a very successful program.
Thank you. Question from the floor.
Hi, Michelle Cortez with Bloomberg. I know this is the longest term data we've seen from this clinical trial. When it was first being developed, there was obviously a lot of questions about the first generation device and the high mortality rates initially. What's a 30,000-foot view now that we have people 3 years out? Does this data change what you think or anyone else on the panel thinks about the value of this technology, considering that it's in patients who are so old? And I think there's been a lot of questions about, how much benefit do you give to someone who's 80 or 90?
Right. I think it's very clear that not only the survival, but also the quality of life improvement in many patients that are in their 80s, even 90s, are worthwhile. The question that you rose is a critical one. How can we identify those patients that perhaps the utility ends and futility of this procedure starts? That's a tough one. Certainly, we're looking at issues of frailty. We're trying to quantify what is frail, more than just an eyeballing a patient. So that's number one. Number two, we are also trying to identify, now we have a large US and non-US data sets that we can look. For example, if you have a very severe chronic obstructive lung disease, very severe, oxygen dependent, that may not be a good sign, so you have to think about that patient twice. If you have severe pulmonary hypertension, a systolic hypertension in the lungs of 90, 100 millimeters mercury, I think maybe a red flag that you have to pay attention to. Chronic liver disease, advanced chronic kidney disease. I think these are all markers of very bad left ventricular function, particularly with large areas of scarring in the myocardium. All these are taken into account now, and I think that we have less so-called cohort C patients in our cath labs these days.
Another question from the floor.
Hi, thank you. Chris Kaiser with MedPage Today. My question is a sort of a follow-up to the previous one. I was wondering if you could let us know what the cardiovascular deaths were, and if you were able to tease out any of the information from all-cause death or cardiovascular death that would identify patients more at risk.
That's right. The cardiovascular death also, the curves are similarly very separate and diverging. But probably within the first year particularly, about 50%, and in some series larger percentage of patients die of non-cardiac causes. I think that's a critically important point. And many of them die with COPD or chronic renal failure or just frailty. I think that those are the patients that we are focusing on, see if we can identify them beforehand.
What makes you
Thank
think
you.
that the bedside
I'm sorry, we
judgment
need
of
to-
frailty is not the best?
I think that there is tremendous inter-observer variability on that. Not only inter-observer variability, but also day-to-day variability. Sometimes I am also guilty of tuning the patients up a little bit and shaving him, and if the patient is lady, putting some makeup and giving a New York Times and sitting the patient up. I think that when that is seen by the surgeon, the decision may be different.
Thank you so much, Dr. Tuju. We can go on for a long time. We're way behind, and I apologize to the press for falling behind here. Thank you very much.